Lunch Symposium. In Room A, we'll focus on respiratory syncytial virus prophylaxis. In Room B, we'll focus on novel pneumonia syndrome testing. And enjoy our lunch symposium in both Room A and Room B.
How to get to main meeting? Please click the red button nearby the stop and close the video button. So just click the red button. We can see the one of the option choose back to main meeting. In conclusion, click red button back to main meeting. So we finish. Thank you.
We have two lunch symposium. In Room A, we'll focus on respiratory syncytial virus prophylaxis. In Room B, we'll focus on novel pneumonia syndrome testing. And enjoy our lunch symposium in both Room A and Room B.
How to get to main meeting? Please click the red button nearby the stop and close the video button. So just click the red button. We can see the one of the option choose back to main meeting. In conclusion, click red button back to main meeting. So we finish. Thank you.
Good afternoon, Madam Chairman, ladies and gentlemen. My name is Tingyu Yan. I come from Taiwan. Thank you for inviting to share the experience of novel pneumonia syndromic testing for pediatric ICU patient care at National Taiwan University Hospital. It's well known that pneumonia is still a serious concern for humans. Even today, pneumonia is still the leading cause of death among children worldwide, especially in developing countries. For children under the age of 5, the mortality rate is as high as 15%, and the community-acquired pneumonia is the most common cause among patients who needed admission due to infectious disease. In the past, diagnostic tests were mainly based on conventional techniques, such as microbial culture, serologic testing, and fluorescent immunoassays. These traditional tests were relatively time-consuming and with low sensitivity. The diagnostic value, therefore, was limited to only 40% in adult patients due to the previous antibiotics exposure or the difficulty of collecting high-quality clinical specimens. And this situation is even more difficult, especially for young children who are often uncooperative for specimen collecting. However, the lack of accurate microbial diagnosis may hamper establishing pathogen-oriented therapeutic plan well. Compared with the majority of community-acquired pneumonia in adult group, as a single microbial infection. The mixed microbial infection rate of pediatric community-acquired pneumonia is up to 40%, especially for children who required admission or ventilator support. So this high misinfection rate will make the diagnosis more difficult, and the therapeutic plan is even more difficult to establish. We know that timely and accurately pathogenic diagnosis is very important for appropriate treatment goal setup. And it also helps to reduce mortality and morbidity. Therefore, I have a dream. I wish no more children die of pneumonia. But how can we make the dream come true? Maybe a modern weapon for diagnosing pneumonia, novel pneumonia syndromic testing based on nested multiplex PCR will be helpful. The Biofile Field Array Pneumonia Panel is a syndromic infectious disease testing for pneumonia. And this test includes 33 targets in one test. It includes 8 viruses, 13 bacteria, and 7 antibiotic-resistant genes in one test. And the turnaround time is about 1 hour only. Next, let's see some evidence for novel pneumonia syndromic testing for adult patients. The first study showed it's a multinational evaluation of the Biofile Field Array Pneumonia Plus panel as compared to the standard of care testing. This study was conducted in 13 European countries and Israel. And there are around 50 laboratories joined this study. Finally, there are more than 1,000 specimens from bath and also more than 1,000 specimens from sputum to test the pneumonia panel. And we can see the results showed when compared to the diagnostic test of standard of care. Novel pneumonia syndromic testing yield the negative detection rate. And on the opposite side, it can detect more bacteria and virus co-detection or viral co-detection pathogen in one test. As a result, pneumonia can generate the comprehensive pathogenic detection results, and this will help to make the potential goal to direct the antimicrobial therapy in near real time and improve antimicrobial stewardship and the patient outcomes. And this is the next study, showed biofile fill rate pneumonia panel for severe lower respiratory tract infections. And this result showed the patient without risk for multi-drug resistance. From the figure A, we can see the negative pathogen detection rate is limited to less than 30%. And it also shows the bacterial viral co-detection or viral co-detection rate increase compared with the standard of care test. And for the patients without risk for multi-drug resistance, the most common pathogens are Streptococcus pneumonia, Haemophilus influenza, Pseudomonas aeruginosa, and Staphylococcus aureus. And the most common viruses are influenza A viruses or parainfluenza virus. And the next slide shows the result among the patients with risk for multi-drug resistance. We can see the most common bacteria were Pseudomonas aeruginosa, Klebsiella pneumonia, Staphylococcus aureus, and Echinobacter baumannii. And all these bacteria yield the high multi-drug resistance rate in clinical practice. So when we face the patient yield these bacteria on their respiratory tract, we should pay more attention to choose the adequate antibiotic treatment for them. And this is the third study. It's about evaluation of multiplex PCR panel for the microbiological diagnosis of pneumonia in hospitalization patients. After incorporation of the pneumonia panel in a diagnostic workup of pneumonia, it can increase the rate of microbiological diagnosis and reveal abundant opportunities for antimicrobial optimizations. So this result will help us to choose the most adequate therapeutic plan for our patients, and this may improve the clinical outcome for them. And the next topic is about novel pneumonia syndromic testing for pediatric ICU patient care. We will show several cases to demonstrate the clinical practice of pneumonia panel. And this is the first case. He is a 3-year-old boy. The underlying disease included infantile idiopathic scoliosis and developmental delay. He suffered from fever, progressing cough with sputum, and tachypnea for 3 days. And the diagnosis was pneumonia with respiratory tract failure, so he received intubation and ventilator support. And this is his chest X-ray. We can see the pneumonia patch is over by the lung field, and this is a severe respiratory distress for these patients. And we use pneumonia panel for diagnosis and for pathogens detected by this test. The results showed Streptococcus pneumonia, Mycoplasma pneumonia, adenovirus, human rhinovirus, and enterovirus. And due to this patient suffer from a severe respiratory failure, and another reason due to the increased instance of macrolide resistant Mycoplasma pneumonia occurred in East and South Asia in past years. So we adjust the antibiotic regimen from vancomycin and ceftazidime to vancomycin and levofloxacin for this patient treatment. And then we can see the fever and the respiratory pattern improve gradually. And this is the second case. She is a 13 years old girl. The underlying disease included Rett syndrome, so she was under anti-epileptic drug control, Baridan, and thalassemia minor. She suffered from fever, productive cough for 3 days, and the distillation was noted on admission day. Pneumonia with respiratory failure and septic shock were diagnosed, and she was under intubation and ventilator support. And we can see the chest X-ray in the first 2 days. A rapid progress infiltration over her bilateral lung field was noted. This is a very rapid progress pneumonia. And the pneumonia panel results showed MRSA and mycoplasma pneumonia. Due to her severe clinical conditions, we adjust the antibody regimen from unacin and doxycycline to teicoplanin and levofloxacin for the community acquired pneumonia treatment. And after we adjust the antibiotics, we can see the fever and the respiratory pattern improve suddenly. So it is evidence if we can choose the adequate therapeutic regimen for the patient, the clinical condition can improve rapidly. And this is the third case. She is a 2 years old girl, and the underlying disease was prematurity. She suffered from fever, progressing cough with sputum, rhinorrhea, dyspnea, and tachypnea for 2 days. And the bronchopneumonia with respiratory distress was diagnosed, so she was under BiPAP support. And this is her chest X-ray. We can see increased infiltration over her lung field. This is a typical picture for viral pneumonia. And maybe you can try to guess how many kinds of viruses detected by pneumonia panel. And this is the answer. We detect adenovirus, parainfluenza virus type 3, and the respiratory syncytial virus in once. And due to this patient is a typical viral pneumonia pattern, and this patient lack any bacterial infection evidence. So during the ICU therapeutic course, we avoided using broad spectrum antibiotics for the whole clinical course. And even though broad spectrum antibody used in this patient, the patient also could improve smoothly. And this is the fourth case. He is a 7-month-old boy, and there was no known underlying disease recorded on the medical chart. He suffered from fever, hoarseness, barking cough, stridor, and dyspnea for 1 day. Coupled with bronchopneumonia and respiratory distress was diagnosed, and the BiPAP was used. And this is his chest X-ray. We can also see increased infiltration over his lung field. And the pneumonia panel results show MRSA coronavirus type NL63, human rhinovirus or enterovirus. For this patient, what's the therapeutic plan for the next step? Due to this patient, he had a typical picture for viral pneumonia. So even we detect MRSA from the pneumonia panel, but we did not use any broad spectrum antibody for this patient, and we discontinue the unasyn and the erythromycin suddenly. But we add muscle contact precaution for the patient's care. And even no more antibiotics were used, the patient can also improve smoothly. So from the previous forecast demonstrated here, we can know if the pathogen detection is accurate and timely. We can set the more accurate therapeutic plan for each patient and avoid unnecessary antibiotic uses. And for severe cases infected by severe bacteria, we can adjust the antibiotics for them immediately, and this will help to the clinical outcome improve soonly. And as a brief summary, we try to summarize our clinical experience for severe community-acquired pneumonia admitted to our pediatric ICUs. And this result was from around 40 patients in our hospital. We can see when compared with diagnostic tests of standard of care, novel pneumonia syndromic testing have much less negative detection rate. The negative detection rate is around 5% in our hospital. And we can detect more mixed pathogens, such as bacterial viral or viral co-detection. The proportion increased significantly when compared with diagnostics of standard of care. So with the pneumonia panel, we have the opportunity to learn the comprehensive pathogenic distribution of severe community-acquired pneumonia in children. Next, let's see some evidence about predictive value of upper respiratory tract specimens. Traditionally, children's lower respiratory tract infections are caused by pathogenic viruses and bacteria in the upper respiratory tract that replicate and spread to the lower respiratory tract and invade the mucosa, resulting in pneumonia and other clinical diseases. And this study showed the infant nasopharyngeal microbiome impacts the severity of lower respiratory infection and the risk of asthma development. So this study gives us a hint. The specimen and the pathogen detected from the upper respiratory specimens can help us to make the diagnosis for the lower respiratory infections. And this is another study. We can see the study showed the nasopharyngeal microbiota can serve as a valid proxy for lower respiratory tract microbiota in childhood lower respiratory tract infections. So this is another evidence to give us a hint. When we get the specimen from the upper respiratory tract, and the pathogen we detect from them can help us to prediction the lower respiratory tract infection and can help us to predict the severity of the clinical diseases. And the clinical value for the above two studies may be when we review our cases and we review the upper and the lower respiratory tract specimens. We use field array respiratory panel for the upper respiratory tract detection and plus quantitative qPCR and the bacterial cultures. So this result to make this figure. And the low respiratory tract specimen will use the pneumonia panel for pathogen detection only. We can see when we compare the pathogen distribution from upper and lower respiratory tract specimens, the pathogen distribution pattern was very, very similar from lower and upper respiratory tract specimens. So this is also give us evidence when the patient suffer from severe community acquired pneumonia who admitted to pediatric ICU care, and the adequate sputum or bar specimen can collect it immediately. We can use the pneumonia panel for diagnosis. But if the patient suffers from community acquired pneumonia, but the clinical condition is well, and the lower respiratory specimens is difficult to collect, at this moment, maybe we can consider to use the respiratory panel for the upper respiratory specimen. And this result can also help us to predict the pathogen over the lower respiratory tract. It may be helpful. And finally, let's see some clinical impact of novel pneumonia syndromic testing. Maybe you will have a question to figure out whether the pathogen detected by pneumonia panel is true or not true pathogen for the patients suffer from severe pneumonia. And maybe this study will give you some answers. And this study shows the relationship of multiplex molecular pneumonia panel results with hospital outcomes and the clinical variable. And the CPIS means the clinical pulmonary infection score. And the patient was divided into three groups. The first group means the patient's cultural and the biofile pneumonia panel all both show negative results. And the second group means the patient's bacterial culture may be negative or false negative, but the biofilm pneumonia panel results show positive finding. And the third group means the patient's bacterial culture and the biofilm pneumonia panel result both show positive finding. We can see whether the bacterial culture is positive or negative. If the pneumonia panel show positive results, the clinical pulmonary infection score will be higher. So this means if the pneumonia panel detects any pathogen, maybe we should pay more attention to these patients because they may suffer from more severe clinical conditions. And I think it's important for clinicians. And in conclusion, novel pneumonia syndromic testing for pediatric ICU patient care, I think it could provide an accurate and a comprehensive understanding of severe pediatric pneumonia. And this state-of-the-art technology can prompt the start of appropriate and targeted antimicrobial therapy. It may reduce the mortality and the morbidity of pneumonia at the disease, especially at early stage. And it might provide important information to help with infection control strategies in ICU setting. And this is my talk. Thank you.